Hi, welcome to session O91. This is chikungunya virus infection and infant neurodevelopment. My name is Randall Waechter. I'm a faculty member at St. George's University in Grenada, West Indies, and also affiliated with the Windward Islands Research and Education Foundation on the St. George's University campus in Grenada. Chikungunya is an alphavirus that is transmitted to humans via the bite of an Aedes aegypti or Aedes albopictus mosquito vector. The virus replicates quickly in the human body, targeting connective tissue, epithelial and endothelial cells, fibroblasts, macrophages, and muscle progenitor cells. This results in a range of clinical manifestations such as high fever, facial swelling, headache, nausea, rash, vomiting, myalgia, and arthralgia. Viremic mothers can transmit CHIKV infection to their neonates. First mother-to-child transmission was identified in La Reunion Island in June of 2005. By April 16, 2006, 38 cases of vertical transmission had been reported in infants less than 10 days of age with high rates of morbidity. Neonates show different clinical presentation from older children and adults. Symptomatic symptoms show up at about 4 days of age. Symptoms such as sepsis, including fever, pain, hypotonia, edema, respiratory difficulties, thrombocytopenia, encephalitis, and disseminated intravascular coagulation are seen. Other symptoms include febrile seizures, diarrhea, vomiting, arthralgia, acrocyanosis, severe bullous, hypo or hyperpigmentation, uremia, lymphopenia, cytolysis, cardiovascular decompensation, and secondary bacterial infections. Vital organ damage and failure have also been reported, including necrotizing enterocolitis, myocarditis, and pericarditis. Developmental outcomes, follow-up studies from La Reunion show that neurocognitive impairment in some perinatally infected children is seen. Deficiencies in the frontal lobes are seen, including language and coordination, and slight deficits in sociability, movement, and posture. The current study complements published data on mother-to-child transmission and the subsequent impact of CHIKV on child neurodevelopmental outcomes by assessing 2-year-old children born to two groups of pregnant mothers, those who are infected and those not infected with CHIKV during the outbreak in Grenada in 2014. The hypothesis was that children infected with CHIKV during the intrapartum period would experience poor neurocognitive outcomes compared to children not infected and not exposed to CHIKV in utero and postpartum. The study protocol was approved by St. George's University IRB, as well as the Stanford University IRB, and in agreement with the Grenada Ministry of Health. Written informed consent was obtained from all study participants. The chikungunya outbreak in Grenada lasted from July to November 2014. All births in Grenada between 2014 and 2016 were obtained from the birth registry and telephone contact information of the mother extracted. Mother-child dyads were eligible for inclusion if the woman gave birth between January 1st, 2014 and February 28th, 2016, and the child was living with the mother at study enrollment. Researchers called mothers as children reached 22 months old and explained the study and invited her to meet with a research assistant who explained the study and obtained written informed consent. Following consent, the mother completed surveys detailing the onset and symptoms related to her CHIKV infection on an electronic tablet, while a trained and certified research assistant completed the neuropsychological assessment with the child. The Intergrowth 21st Neurodevelopment Assessment was used to measure child neurodevelopment. It is a multidimensional standardized assessment measuring cognition, motor, language, and behavior outcomes in children aged 22 to 30 months. Laboratory assessment consisted of CHIKV infection status, as defined by IgG and IgM ELISA results in mothers and children. All maternal and child serum samples collected during the assessment were thawed and initially screened by IgG ELISA to confirm CHIKV infection. All children with positive IgG results were further tested for recent exposure by IgM ELISA to rule out infection in the previous 6 to 12 months. The following groups were established for the present study based on CHIKV ELISA test results. Mothers and infants were assigned to categories of chikungunya infection based on the CHIKV ELISA blood test results. There are approximately 1,500 births per year in Grenada. We contacted 1,560 mothers, 829 of whom declined to participate in the study, leaving 731 mother-infant dyads. 85 mothers were excluded from the analysis because of missing data. 92 infants were excluded from the analysis because of missing data. Of the 646 mothers, 485 or 75% were IgG positive for chikungunya virus exposure. This is consistent with estimates of population exposure to the virus in Grenada, which potentially reached herd immunity, causing infections to drop precipitously at the end of the outbreak. Of the 639 infants, 47 or 7.4% were IgG positive for chikungunya virus exposure. Comparison of the 47 CHIKV infected children against the 592 uninfected children showed no differences in infant gender or age. Comparison of the 19 postpartum CHIKV infected children against 592 uninfected children showed no difference in the infant gender or age. Comparison of the 149 children exposed to CHIKV, that is, children who were born to mothers who tested positive for CHIKV infection and had confirmed symptoms of CHIKV during pregnancy, against the 161 unexposed children showed some significant differences. Specifically, mothers of CHIKV unexposed children were more likely to be in a relationship, and mothers of CHIKV exposed children were more likely to have a lower income. There were no significant differences between CHIKV infected and uninfected children across the neurodevelopmental domains measured by the inter-NDA. There was, however, a significant difference in negative behavior scores between CHIKV exposed and CHIKV unexposed children. However, the difference in negative behavior scores between the CHIKV exposed and CHIKV unexposed children was not meaningful. That is, the range of scores for both groups fell within the normal limits on the inter-NDA, as indicated by the red and blue lines within the green range on the associated chart. In fact, the range of scores for both groups for all the inter-NDA domains fell within the normal range of scores on the inter-NDA. So in this study, we observed no difference in neurodevelopment at 2 years of age in children exposed to CHIKV in utero, nor those infected with CHIKV in the first 2 years of life compared to uninfected peers. Timing of maternal infection with CHIKV during gestation and the severity of maternal chikungunya disease were not associated with neurodevelopmental outcome either. These results are consistent with previous findings in La Reunion, which only showed neurodevelopmental impacts in children who were infected with CHIKV during the intrapartum period. In this study, we only had one mother who was infected with CHIKV during the intrapartum period. Therefore, we didn't have a large enough sample size to confirm the findings from La Reunion about intrapartum infection impacting child neurodevelopmental outcomes. So in conclusion, it seems that children who are exposed to CHIKV infection from mothers who are infected outside of the intrapartum period do not experience neurodevelopmental outcomes as a preliminary finding, but given the lack of data on chikungunya infection and child neurodevelopmental outcomes, further studies are needed. Thank you to my co-investigators and to Grenadian mothers and infants for participating in the study, as well as the Grenada Ministry of Health and the Saving Brains Grenada research team.